Okay, good morning, everybody. I guess we'll go ahead and get started. My name is James Field, and it is my pleasure to introduce the speakers for the next plenary session. I am the newest team member to the North American Management as the Deputy Director of Health and Karen's sidekick here. And for the second plenary, Health Policy and Aging Advocacy, we have three profound speakers. Our first speaker is Colleen Myman. Colleen is a senior health policy analyst in the Office of Policy Analysis within the Health Resources and Services Administration. HRSA is known as the Access Agency and administers numerous programs designed to increase access to health care for underserved populations, such as the Health Center program. Colleen's work generally focuses on finance and coverage issues, including cross-cutting issues that involve both HRSA and the Center of Medicare and Medicaid Services. Prior to joining HRSA, Colleen worked as the Medicare and Medicaid analyst in the HHS Office of the Secretary and as legislative analyst for Senator Bill Bradley of New Jersey. Our second speaker is Marissa Scolafoli. Marissa serves as the acting director of the Office of Policy, Analysis, and Development in the Center for Disability and Aging Policy at the U.S. Administration for Community Living. At ACL, she identifies and analyzes emerging policy issues and trends related to health care, aging, and disability. Prior to joining ACL, she served as the director of the National Center for Benefit Outreach and Enrollment in the National Council on Aging, and has worked her entire career in the field of aging on issues related to developing accessible education materials and infrastructure for health care and long-term care education for consumers and professionals. And then our third speaker is Sandy Markwood. Sandy is the CEO of the National Association of Area Agency on Aging, or N4A, the organization which represents the nation's 618 area agencies on aging and serves as a champion of more than 246 Title VI Native American aging programs. I lost my place there. Adults in NC4 is dedicated to building the capacity of its members to advocate on behalf of older adults and their caregivers, take action to ensure that communities are equipped to support and enhance the well-being of older adults, persons in disability, and their caregivers, and serve as the focal point in the community for answers on aging. Prior to joining N4A, Sandy worked for 20 years at the National Association of Counties, the National League of Cities, and as the associate to the county executive in Albemarle, County, Virginia. Each speaker will have about 15 minutes for their presentation. However, the question and answers will be held to the end, but Colleen will take question and answers right after her session. Okay? So please join me in welcoming Colleen Myman.
Hi, everybody. A couple things here. First of all, thank you for whoever managed to figure out how to get my slides up here. I didn't actually expect them to be here, so I'm not planning on talking off of that, but I might just kind of follow along as I go. But I have to say that I'm a little envious of Dr. Karpiak and previous people because they got to get up here and talk about sex and other stuff, and I get to get up here and talk about the almost just as sexy topic of CPT coding. So, which is, so really, if you haven't gotten more coffee, you might want to now. But But believe it or not, CPT coding and Medicare payment is incredibly important. I've always been a bit of a fish out of water in the HRSA Health Center world, which is the agency I work with. I was with the Health Center program for about 13 years till I moved to the policy office for the whole agency. But I really believe in to quote Deep Throat, if we're getting back to that topic, you have to follow the money. If there are so many things that we're talking about up here that are so important to the well-being of our seniors, but we're not going to be able to do any of those things if we don't have the resources to do it. And I'm here specifically to talk about the Medicare, how Medicare pays federally qualified health centers for services that are provided to seniors. So even if you're not a federally qualified health center, though, I'd urge you to pay a little bit of attention because this is actually big news. And the positive side is that there is the potential for significantly increased reimbursement from Medicare to health centers starting later this year. The downside is, and this is where we get back to CPT coding, if you're a health center and your charge system and your CPT coding is not up to snuff, there is also a very significant risk that you could get yourself in really big trouble with Medicare. Okay? So, plus side, big opportunity for more money. To do all these things that we've been talking about. Downside, I'm calling this new system the tail that wags the dog. If you are a health center and you do not have your act together around CPT coding, and you do not have your act together around your fee schedules, this is going to highlight those issues in a way that it's not just going to be HRSA who's going to be on your case about it. It is going to be CMS and CMS recovery audit contractors and all of those people. And if you have anything to do with healthcare financing, you know that CMS recovery audit contractors is one of the last words you want to hear. So please, as I said, this is a big opportunity on the positive side and a big risk on the negative side. So let me just back up here a little bit here to my notes. Okay, so what I'm going to talk about is Medicare later this fall is going to start rolling out a brand new system to pay health centers. And this is a big deal. The last time this system was touched was in 1992, so we're looking at over 2 decades, okay? But once again, as I said, an opportunity and a very significant risk if you don't have your act together. Now, by way of background, if you go back and you read the congressional record on why health centers federally qualified health centers have a different payment system from any other provider in Medicare and Medicaid, with the partial exception of rural health clinics, it's a very specific reason. It's because the vast majority of these health centers are getting grants from HRSA, from the federal government, that are supposed to be used to offset the costs for patients who are uninsured, or patients who are underinsured, or patients whose insurance only pays for part of the services, like Medicare and Medicaid does not pay for the enabling services that health centers are required by law to pay for, okay? So you're supposed to have the grant money, and that's just supposed to go for that. And 20 years ago, people started saying, hey, wait a second, Medicare and Medicaid is not paying their full share. It's costing us this much to care for a Medicare patient, and Medicare is only paying us this much. So this money here is coming out of our grant. And Congress, you're telling us, HRSA, you're telling us that grant money's got to go to pay for Medicare, to pay for uninsured? We can't do that because Medicare and Medicaid aren't pulling their fair share. So that's the origin of why health centers have an unusual funding system, is to make sure that they're not tapping into their grant funds to pay for patients that are supposed to be paid otherwise. So that's a very nice theory, but the argument has been for a long time, and it's easier to make the case in Medicare because you have a national system. But the argument has been in Medicare for a long time that, hey, Medicare has this system in place with all these caps and all these productivity screens. Bottom line, Medicare isn't paying their fair share. And health centers are having to use other funding sources to cover the cost of Medicare patients. And lots of discussion, and you can guess who took what side of that, but in 2009, CMS, GAO did a study and concluded that there was a lot of validity to that argument, that health centers were underpaid about 20% versus what their actual costs were on average for Medicare patients. So that gave a lot of impetus to people who were pushing for a new payment system. the fact that there was now proof, objective proof, that health centers were getting underpaid relative to their costs for these patients, relevant to their reasonable approved cost per CMS, so not just whatever cost they chose to throw out there. That combined with the fact that on average, health centers have about maybe 8% of their patients are Medicare, but that number's been growing pretty consistently over time. And it also varies enormously by health center. My guess is that if you're here, you're probably one of those health centers that has a much higher percentage of Medicare patients. But as I said, that overall number is increasing throughout the country. Part of it is that the population is aging. Part of it appears to be that health centers are doing a better job of keeping their patients once they age onto Medicare. Part of it is that health centers are growing and just bringing in more patients. So at any rate, you have all these factors coming together, and along comes the ACA. And what happened in the ACA included language saying new payment system for Medicare, for health centers, for FQHCs specifically. And this new system needs to actually reimburse health centers 100% of their actual cost. Their approved cost, so you can't just obviously run up a trip to Barbados or whatever and shove it in there. So this new system gets put in the ACA, and it's supposed to go into effect this October. And CMS puts out a proposed rule last September, and everything seems to be fine. And thankfully, for those of you who are members of national advocacy organizations, the advocacy organizations read the statute more carefully than, I'm embarrassed to admit, people like I did, and more carefully than the people at CMS did. And they said, whoa, baby, there's a problem here, okay? If you only take 4 things away from this whole presentation, here is thing number 1 to take away. The Medicare PPS is majorly different from the Medicaid PPS, okay? It works very differently on a lot of levels. I keep talking to health centers who say, oh, Medicaid, now we're getting PPS under Medicare. We'll get the same payment rate we get under Medicaid. No, very different. So please, that's thing number 1 to take away. They are alike pretty much in name only, okay? Other than the fact that you get a per visit payment, but even that is more complicated in Medicaid. And anyway, so when the advocacy groups looked at this law, they said, wow, in Medicaid, each health center gets a rate, and every time you have a visit, you get that rate. So your rate must be $140, and every time somebody comes in, you get your $140. Well, first thing is, in the Medicare world, and we knew this, every health center doesn't have a different rate. There's a national rate, and it gets adjusted for geography. So every health center in Phoenixville, Pennsylvania might get the same rate, but it's a slightly different rate from the 5 miles down the road. Okay. But that wasn't the part that was concerning to people. What was concerning to people was the law, if you read it really closely, says you get paid the lesser of the PPS rate, which is this national rate adjusted for geography, or your actual charges. And here's the rub, and here's where the CPT coding comes in. The charges need to be calculated based on all of your CPT codes that are listed on the claim, and whatever your official health center fee schedule says the charge is for that service. 2 problems there. So we got 2 factors, CPT codes and charges. Number 1, health centers are, and this is not an official government opinion, really, really not good at coding. It's my opinion. We started asking health centers to do detailed CPT coding in 2011 in advance of this new system coming in. Over 95% of health center claims that came into Medicare said that the patient got one service and one service only. They got an E&M visit, whatever that is, 994, whatever, I forget the code now. One service only. I can't sign the desk at my primary care doctor's office and only get one code, okay? When I go into my primary care doctor, I come out with a list of not 17, but it seems like an awful lot. There's always 3 or 4 codes for what we're done. But health centers were putting down one code consistently. And I can tell you, it's been hard for me as the person who tries to advocate within the administration for health centers. And I say, it's a bundled rate. Health centers do a lot during this one visit. And we say, okay, health centers, here, show us what you're doing. And they come back and they give us one code. And they're doing, according to their codes, way less per visit than the average doc down the street is doing. So I understand from the perspective of a doctor who's doing 17,000 things, CPT coding is very unimportant. You get the same rate under Medicaid, whether you list one CPT code or 10, okay? But it's really, really starting to matter now in Medicare, because they look at your CPT codes and then they look at your charges. And they say, okay, well, if the charge for this is this. And when they look at your charges, they look at what you would have, what your fee schedule says, which is what you will charge to an uninsured patient above 200% of the poverty line, okay? And they add those things together. So now you've got a situation where you have a health center that's probably not listing all their CPT codes. And their charges, in many cases, have not been updated since I don't want to know when. And suddenly you say, okay, well, the Medicare rate is $159. But when you actually take the CPT codes, you multiply them by the charges, it comes out to be about $48 or whatever. Which number is the health center going to get? And what the lawyers realized was they're going to get that $48 fee because their CPT codes and their charges are not up to date. Well, this got discovered, and the first reaction was, oh, no, we couldn't have missed something that important. You know, we in the administration, we know what we're doing too well. Well, obviously, we didn't know what we were doing. And then this massive tizzy went off of, oh my goodness, we didn't realize what was up here. And CMS did, I've joked, having been in HHS for about 20 years now, that I've seen a lot of regulatory gymnastics done over the years. CMS did what I would consider to be regulatory acrobatics. They went above and beyond to try to deal with this situation, because the idea, as I said, when Congress passed this law, was to make sure health centers got paid their full cost. And the estimate was that that could result in health centers getting a 30% increase. And then when they went back and factored in this lesser than piece, suddenly health centers are looking at losing a lot of money under this new system. Whole thing flipped on its head, okay? So CMS got very creative, and they came up with this idea, and they said, you know what, just because of the way the math works out, even if your CPT coding and your charges are right, if you get paid the lesser than this average rate, well, you're going to end up losing money all the time. So they came up with this rather creative idea of creating something called a G code. And many of you who are in billing will know that G code is basically a procedure code that Medicare made up for its own purposes, or CMS made up. And what they're going to allow health centers to do, and now this came out in the final rule, which was just released early last month. But early last month, May, new system goes into place as soon as October, depending on your fiscal year. Not much time to get in line here. What they're going to do is allow health centers to put together like an average rate. Say, okay, on average, when a Medicare patient comes in, we do this much stuff and it costs this much money, and this is our average rate. And every time a Medicare patient comes in, you will get paid the lesser of whatever that PPS national rate is, or the average rate. So, sounds good. The thing is, though, so you set that average rate, and if you were being a little cynical, you'd say, wow, I'll set that average rate 1 cent above what the PPS rate is, and I'll always get my PPS rate. Well, there's some real risks that you need to be aware of there. The first one is, let's say you set that rate too low. Let's say your real cost for a Medicare patient are, to make up a number, $140. And you set your G code rate at $120. You're leaving $20 on the table every day. Congress actually gave you a chance to be reimbursed your full cost. And if you don't get that G code right, you're leaving money on the table. Now here's the flip side of that. Let's say your actual costs are $120. And you put your charges at $140, okay? When you submit your bills to Medicare, you're gonna need to put on there your CPT codes and your charges. And Medicare at some point in the future is going to go back and say, gee, you said your charges averaged out to $140, but we've been matching up your CPT codes and your charges, and wow, on average it only comes out to $120. You've been being overpaid by $20 every visit for however long. And now we're going to add on penalties, and now we're going to add on interest, and now we're going to add on everything else. Not to mention, we might shut down your participation in the Medicare program. The point is, if you hit that number wrong, that whatever your actual charges or costs are, you're leaving money on the table. If you put that number too high, you're really putting yourself at risk. So the bottom line is, if you don't already, you need to get your providers coding properly. I know it is the least sexy topic on the planet, but you need to do that to avoid leaving money on the table and to avoid getting in trouble with Medicare. And the second thing is your fee schedule has to be accurate. A lot of health centers haven't updated their fee schedules in years, and they're like, well, maybe this this should be $200, but almost all of our patients are on the sliding fee scale, so we'll make it $100 and give a 50% discount. No, suddenly those charges matter. If that service really should have been $200, you need to have it at $200 and discount it at 75 to get it down to 75% to get it down for your patients, okay? Because Medicare is going to be looking at those charges, and you need to be charging the exact same charges to Medicare that you charge for everybody else. You have one fee schedule, period. One fee schedule, one adjustment based on the sliding fee. That's it. So, any rate, just in terms of the transition and things, as I said, the new system starts this October. It will phase in for health centers as whenever the new fiscal year starts. They're all in different fiscal years, different cost reporting years. Another big thing that was a change in the final rule that came out, if you have a patient who comes in for both a mental health and a primary care visit in the same day, you can bill separately. You can bill them as 2 visits. And you can get 2 payment rates. Remember, the payment rate is the greater of your PPS rate or your charge rate, your G-code rate that you've hopefully set correctly with accurate CPT coding and charges. Have I beat that point home yet? Okay, so if you want more information on this, there's tons of information online. I'm happy to share this. This was a document that CMS did a national provider call earlier this month to go over the high level, some of what I've done. They're also doing a call later this month on June 25th at 1:30 Eastern, where they're going to get a lot more into the details about the G-codes. Now, by law, obviously, CMS cannot tell you how to set your G-codes, but what the G-code should represent your actual cost, and your CPT codes times your charges should get you there. If those things don't line up, you've got an issue. So, okay, just to beat the horse dead, if you only take away 5 things, I keep adding the things, this is it. Number 1, if you've got Medicare patients, this is a big deal. This is the biggest change in 22 years, and it is the tail that is wagging the dog. Number 2, this is an opportunity. There is more money on the table if you're losing money on your Medicare patients. This is your chance to make that up. That does not happen in this Congress very often, believe me, okay? But there is also a risk of the recovery audit contractors knocking at your door. Number 3, coding matters. I know that is the last thing that your providers want to deal with. Maybe you assign somebody who just deals with coding. But health centers are not coding accurately right now, I am sure of it. They're not listing all the appropriate codes, and that is really going to start to matter. Number 4, charges matter. Your fee schedule needs to be reflective, one fee schedule for everybody, and then the sliding discount that goes on it. It applies that for people who are below 200% of poverty. That needs to be accurate. By law, it has to reflect prevailing rates in the community and your actual cost. And just number 5, forget everything you know about Medicaid PPS. It might sound the same. This is a very, very different system, different rates, different ways that things are calculated, different people you have to keep happy, all of those sorts of things. So those are my final 5 points. Thank you.
Okay, at this time, we'd like to open up a few questions for Colleen. Does anybody have any questions?
I told you it wasn't very sexy.
Missed your opportunity. Oh,
What kind of materials besides the call are available to health centers who need to update their CPT codes?
The question was what type of materials are available? Oh, wait, that's on. To health centers who want to update their CPT codes. The feds cannot actually get involved in that. I mean, that's something that ideally an organization should be taking care of on their own. I suspect that the National Association of Community Health Centers is going to be putting a lot of information out. This is one of those things that if it hasn't been done properly up till now, it's best that that not be brought to anyone's attention. It's just best that it be fixed. But I would be talking to NAC, National Association of Community Health Centers, about how to do this. And just basically your charges ought to match, your cost ought to match your charges, ought to match your CPT codes, all that stuff. There's just such a higher emphasis on data, improving what you're doing, and also concern about fraud and abuse in DC these days. It's really something you have to pay attention to. It's, once again, not the sexiest topic, but let me tell you, when those RAC people show up at your door, you'll really regret that you didn't.
Is there any other questions? No? Okay, our next speaker, Marissa.
Okay, there we go. It's taking a minute for it to show up on the screen. I thought, what am I doing wrong? No. Okay. So, good morning, everyone. My name is Marisa Scalafoli. I'm the acting director of the Office of Policy Analysis and Development, which is part of, we have a dizzying list of acronyms, but the Center for Disability and Aging Policy at the Administration for Community Living. And my charge today, and it's interesting to follow Colleen, who was talking about sort of CPT codes and business and, sort of getting your rates right. And what I spend a lot of time on these days in the course of my job is really, in large part, working with Sandy and the National Association of Area Agencies on Aging, is trying to build the business capacity of the aging and disability community-based organizations and state organizations that we work with to be part of sort of the rapid fire changes that are happening in states to the healthcare and long-term services and support systems. So that's a lot of what I do. But my charge today was really to talk about a little bit about ACL and about the programs that we sponsor, that we fund, that can be helpful to you in federally qualified health centers. So a little bit about ACL. We were created, it may be an unfamiliar name to a lot of people. And ACL came about in 2012. And were designed to develop policies and improve supports for older adults and people with disabilities of all ages. The ACL combined the Administration on Aging, with which you may be more familiar, the Office on Disability within HHS, and the Administration for Intellectual and Developmental Disabilities. The AOA part of ACL leads our national aging network. There are 56 units on age, state units on aging, over 400 tribes and tribal organizations, over 600 area agencies on aging, which I know Sandy will talk more about. And really the backbone, at the local level are these area agencies on aging and the providers with whom they work. And ACL right now consists of 5 centers. The Administration on Aging, the Center for Disability and Aging Policy, where I work, the Administration for Intellectual and Developmental Disabilities, our Office of Regional Operations, and I know you'll hear from Kathleen later on in this meeting, as well as our Center for Management and Budget. So that's a little bit about ACL and its component parts. But my job today, given our focus, is really to talk about the aging services that can be of use to federally qualified health centers and your partners and providers out in the field. So here are the types of services that the Aging Network offers. You heard Bob Blancato before talk about access to benefits being so critical. Access services are one of the things that the Aging Network provides, as well as in-home supportive services, services for caregivers, issues related to elder rights, which I know you heard a lot about from Bob, health-related services, which I'm going to spend a fair amount of time on during the time that I have with you all, as well as nutrition services. So I mentioned this issue of business capacity and business acumen, and so a lot of what we're doing these days is really trying to talk to health systems and accountable care organizations and health plans around the country to talk about where the aging and disability networks, in particular community-based organizations, add value to the changes that are happening around the country as a result of the Affordable Care Act and other things that are happening in states to change the healthcare and long-term services and support systems. And we talk about them largely in 4 different buckets. And I'll get into some of the sort of sub-bullets on these on my upcoming slides. But we talk about where our networks can add value is managing chronic conditions, providing services such as the Stanford model of chronic disease self-management, or meals, as Bob talked about before, education about the Medicare preventive benefits, which I know was talked about in the last session, diabetes self-management training, and so forth. Activating beneficiaries I think in the healthcare world, we always sort of have this tussle about language because the healthcare world, you talk about sort of everybody as patients, and we talk about them as clients or beneficiaries or consumers. So we talk about activating beneficiaries, really getting them to play a more engaged role in the care that they're receiving. So our networks provide services such as person-centered planning, evidence-based care transition services, which I'll talk about, benefits outreach and enrollment, caregiver support, and more. That sort of the box at the bottom, diversion or avoiding long-term residential stays. These are all issues that we know are critical to health plans and critical to achieving the 3-part aim of better health, better care, and lower costs. Well, certainly having people stay in their own homes where they want to be and avoiding being in longer term residential facilities unless it's absolutely necessary is one of the key things that we think can drive achieving that 3-part aim. So our networks offer services related to nursing facility transitions. I talked about person-centered planning. We also do assessment and pre-admission review and more. You heard Bob mention how critical preventing hospital readmissions is to all of the aims that we're trying to achieve under the Affordable Care Act, and especially with delivery system reforms. I would also argue that not only preventing readmissions, but preventing hospital admissions to begin with is really important to this equation. And you see all the different kinds of services we offer, and I'm not going to go over the same ones again, but some other ones that add into the equation. Evidence-based medication reconciliation systems. That's some of the work that we've funded over the years in terms of evidence-based programs, falls prevention and home risk assessments, environmental modifications, and connections to long-term services and supports. So managing chronic conditions, that was one of the big sort of buckets that I talked about on that last screen. Chronic disease self-management education is an evidence-based approach. And when we're talking about evidence-based approach, we're talking about really those tested programs. They've been tested in randomized control trials. They've been published in peer-reviewed journals and found to have a positive impact on the populations that they're designed to serve. So our network has been offering chronic disease self-management programs that provide older adults and persons with disabilities with the education and tools that can help them to better manage chronic conditions, such as diabetes, heart disease, arthritis, and depression. So one example of that, the Chronic Disease Self-Management Program. The Chronic Disease Self-Management Program is a workshop that's given 2.5 hours once a week for 6 weeks in a variety of different types of community settings like senior centers and so forth, libraries, hospitals, and people with different kinds of chronic health conditions attend together. They're facilitated by 2 trained lay leaders, and one or both of whom have chronic conditions themselves. And they cover subjects such as dealing with fatigue or pain or frustration, exercise for maintaining their health, appropriate use of medications, and a variety of different types of topics. And a national study has shown that these programs, which our networks deliver, can help to achieve that 3-part aim of better care, better health, and lower costs. AOA as part of ACL has also been engaged in chronic disease self-management over the years. We have a long now, over 10-year history in this field, working with partners in the field such as the National Council on Aging and the National Association of Area Agencies on Aging and other partners. And the first sort of 10 years of funding, this first 10 years of evidence-based grants, were really designed to translate evidence-based interventions that were tested in randomized control trials. And one of the most successful of those translations was the chronic disease self-management program that I talked about before. And these programs have now helped over 200,000 people in the past 8 years. So I also mentioned in the context of managing chronic conditions, diabetes self-management. As you may know, Medicare offers a diabetes self-management training benefit. Area agencies on aging and other community-based organizations play a role in expanding the use of diabetes self-management training through a variety of different types of grants. 39 states now provide diabetes self-management program training, or the DSMP, and we provide technical assistance resources on how to achieve accreditation from the American Diabetes Association or the American Association of Diabetes Educators. And hopefully this leads to, and again, this business acumen piece and sort of reimbursement. Hopefully for some of our AAAs, it has led to them being able to achieve Medicare reimbursement for these services. So care transitions. One of the things, is critical to preventing hospital readmissions is achieving better transition. So from hospital to home, from hospital to skilled nursing facility, from skilled nursing facility to home. We had a grant program, the Aging and Disability Resource Center Evidence-Based Care Transitions Program. Wow, that was a mouthful. That was really designed, and again, you'll see this theme running through these slides of evidence-based programs. That's been an increasing emphasis in all of our programs over the past several years. It's really not just, wow, these are great programs, we really think we ought to provide them, but really what is the evidence base behind them that can help them to achieve better health outcomes for the populations we serve, or help them to stay at home where all these people want to be and want to live. So these care transitions model were really engaged. They're evidence-based approaches. We awarded grants to 16 states to implement these in their states and in specific communities within their states that were designed to engage older adults and their caregivers in these transitions and use different evidence-based models in which to do that. So I'm sort of running through a lot of these. You can get information about all of these on our website, which is at acl.gov. It'll be on our last slide. And for those of you who want links to more specific information about any of these programs, I'm more than happy to connect with myself or Kathleen or our colleague Danielle Nelson is there in the middle of the room on any, if you'd like more information about any of these programs, we're happy to get that to you. So caregiver support services, the National Family Caregiver Support Program, it was it sort of came into being under the 2000 Older Americans Act reauthorization, and as I think you heard from Bob, the Older Americans Act is really sort of the backbone of not only AOA, but the aging network in general. And it was the first federal grant program that was designed to meet the needs of unpaid family caregivers. There are 5 different categories of services. These programs serve 1 million caregivers annually. And what we've learned from surveys that we've done is that this program helped 78% of caregivers say that this program enabled them to provide care longer in their homes to the older adults with whom they live, as well as to 93% of caregivers rated those services as good to excellent. So this has been a program that has really become increasingly important, not only within our agency and our network, but to the older adults and the caregivers with whom they serve. I know I'm getting close, I think, to the end of my time. Yes, so I'm gonna really just go through these last couple of slides really quickly. Also critical in terms of preventing hospital admissions and readmissions is falls prevention. In 2003, we awarded AOA awarded grants to 24 states to develop infrastructure and partnerships to work with embedding programs, health and prevention programs within communities such as that would help to prevent falls. This programs we support include programs such as A Matter of Balance, Stepping On, and Tai Chi, Moving for Better Balance. What may be of most interest right now from this is that we have new funding that is available that will start September 1 that is designed to help the Aging Network to provide falls management and prevention programs to older adults. And that funding is about $4 million for 8 to 10 states and 5 tribes. I talked before about also important what we've learned through the care transitions work we've done is not only sort of managing people for that 30 days or 60 days after they get out of the hospital, but really what we've learned is critical is connection to longer term services and supports that can help people to stay in their homes and not to go back to the hospital. And the supportive services that we provide through the Older Americans Act include nutrition services, as I talked about before, services for tribes and tribal organizations. We have about $1 billion in funding that goes to serving 10 million older adults every year. And these programs serve 1 in 5 older adult people over age 60. And the last program that I really quickly wanted to mention that gets at this aim of preventing readmissions has to do with services and supports for persons with dementia. Since 1992, we've been supporting the Alzheimer's Disease Supportive Services Program, and again, which has had a shift toward more evidence-based programs in the past several years. And these translated evidence-based interventions have been shown to decrease caregiver depression and burden and increase caregiver knowledge and their ability to feel confident in the services that they are providing to their loved ones, as well as to cope more with their situation as caregivers. There's a new Alzheimer's program right now that is underway with funding from the Prevention and Public Health Fund that you see here on the screen. So I know I've gone through a lot of programs really sort of rapid fire. We welcome these connections, both at the national level, at the state level, and at the local level with the programs and services that our networks provide. Federally qualified health centers are incredibly important partners to our networks. So we welcome the opportunity to connect with you and to answer any questions that you might have after Sandy talks. And there we go. 15 minutes. All right, there we go. Oops. I'm trying. There we go. I know you're here. Let's see, there you go. Is that you? That's you.
Me, and then
Okay,
we'll just
yeah, yours. We'll get you on slideshow.
Perfect. Thank you.
Uh-huh. Oh, I'll take my water.
All right. Well, good morning. Thank you for the opportunity to having me here today to talk about both two issues that I love to talk about. One is partnerships and the way that I think that our communities can work together. And I'd like to point out a number of different ways to do that. But the other important part of my conversation with you this morning is looking at the partnerships that we really all need to forge together to ensure that we are really developing healthy communities that are good places to grow up and to grow old, which is a policy as well as a programmatic priority of our organization, the National Association of Area Agencies on Aging. For those in the audience, how many of you know your area agency on aging, or if you're living in a tribal, on a reservation, your Title VI Native American Aging Program? All right, well, by the end of this, I'm going to make sure that you know how to connect with area agencies on aging. But in looking at this, why should we care about healthy aging? One, the demographics, which I know that you know, but traditionally, when you look at it at the community level, most people don't know the demographics of your communities as well as they should, and they certainly don't know the demographics of the aging population. The rates of disability within the aging population, chronic disease, which has already been mentioned, rising healthcare costs, workforce and economic growth, and the critical need for not only physicians and healthcare providers, but other supportive workforce participants to be able to support an aging population. And also the reality that when we're talking about an aging population, oftentimes we talk, especially on the healthcare front, about the deficits, about the fact that the aging population has chronic diseases and has frailties. But in looking at that, I also want to reinforce the fact that the aging population is a huge, not only economic driver at the community level, but also a social capital force that community health centers as well as the aging network need to capitalize on. So the demographics, we all know this, the rapid rise in the aging population, particularly those people who are 85 plus. And in looking at that, in looking at the aging population, I just want to reinforce the fact that when we're looking and defining who's old, we really need to ensure that as we do this with our staffs at the community health centers, that you translate what we've translated out into the community is, when you're looking at the face of an older adult, that face has changed. And I wish my face looked like Tina Turner. We're talking about, making this a sexy presentation, that's why I put her picture up here. But in looking at that is recognizing that when we're talking about older adults, no matter where you put the marker, in the Older Americans Act, we put it at 60. But if you're in a room in your community, if you're in a senior center and you start asking people when they're old, and Kathleen, you may have touched on this, you 60, nobody's hands go up, 65, 75, 85. It's not till you get to 95 and 100 that people's hands go, well, maybe. So in looking at that is when we're talking about age, we need to recognize the fact that age is a relative term to people, especially as they're older, and to the baby boomers even more so. Because we really, if you say older adult or elderly, we're going to walk the other way. So if you're looking and reaching out to an aging population, especially baby boomers, and I fall into that category, you really need to look at how you react and reach out to them. So in looking at that, we're needing to face meeting the needs of multiple generations. Now, in saying this, the Rolling Stones, the average age of the Rolling Stones is older than the Supreme Court justices. So the Rolling Stones are part of the aging cohort, as are the people at the bottom of the screen. So again, reinforcing multi-generational aging across the community. But what are the factors that impact health and livability, and how can we work together on those? One is looking at the fact that most older adults are living in the community. That's the big bar, and very few of them are living in long-term care facilities, the top bar, or in community housing with services. So when we're talking about aging in place, and we're talking about creating communities that are good places to grow up and to grow old, the fact is that's where people are aging, and if I asked each of you, that's probably where most of you would like to age as well. But to age successfully at the community level, we also need to really recognize the fact that there are many people as they age who need assistance with activities of daily living, bathing, feeding, the basics of life, as well as IADLs, those things that, chore services, answering the phone, things that really, with a little bit of assistance on the activities of daily living and the IADLs, people can live successfully at the community level. And that's where our partnerships, I really believe, come into play. Also, when we're looking at chronic disease, which has been raised here today, different statistics. 4 out of 5 older adults have one chronic disease. 50% have more than 2 chronic diseases. So chronic disease is a factor from health and aging that we need to tackle and react and respond to. And part of that is looking at keeping people active at the community level. And this chart concerns me, as I'm sure it concerns you, when you're looking at the number of older adults 45 plus who report that they are active, physically active. I mean, this is abysmal. And when we add that on to the discussion that Bob Blancato had about how many older adults are are compromised, are hungry, how many older adults aren't getting the nutrition they need to be healthy. So you add two really important pillars, nutrition and physical activity, and you can see how important our partnership between the Aging Network and community health centers is as far as trying to tackle that. So as we're looking at promoting healthy communities for older adults, there are some things that we need to think about together. Supporting access to information about community services and support so that people know that there are programs like yours and ours out at the community level. And Marisa highlighted so well the range of services that area agencies do. You know the services that you provide in the health arena. Making sure that people understand that there are home and community-based services before they're in crisis. As Marisa said and Bob said, N4A operates the Elder Care Locator, which is a 1-800 number for the Administration on Aging, so older adults, caregivers, professionals can find out about home and community-based services for older adults at the community level. And oftentimes what we get are the calls when people are in crisis, when they're looking at trying to put mom in a nursing home, and you delve into that call a little bit further and you find out mom doesn't need a nursing home, mom needs a ride to the doctor every week, and the caregiver can't leave work to do that. Mom needs a home delivered meal 5 days a week when the adult daughter can't be there except on the weekends. So when you put together these critical home and community-based services, it improves the health, it improves the well-being and independence. But also looking at, again, adequate nutrition, physical activity, promoting health promotion, disease prevention, which is what we do together, access to medical and other transportation, and also making sure that people aren't isolated, that they're engaged in their community. So as we're looking at the roles of area agencies on aging, I just wanted to reinforce these because I think these are areas where we can partner. One is, as community health centers are working more and more with a growing older population, area agencies on aging are working more and more with a population below the age of 60, and really working to serve people with disabilities of all ages, as well as caregivers, and also because of an MOU between the Administration for Community Living and the Veterans Administration, providing home and community-based services to veterans of all ages. So also, what do? Evidence-based health promotion, Marisa pointed out. Health insurance and benefit counseling, which was pointed out this morning, is so important for access to programs like SNAP and Medicare Part D. Also looking at case management, helping people manage all the services that they need at the community level. Critical respite to caregivers who are caring, and we know that caregivers are the backbone of the long-term services and supports system in this country, as well as assessment to determine what the care needs of an individual are. So services related to health care delivery specifically, in addition to those I just pointed out, is looking at options counseling through the Aging and Disability Resource Centers, providing personal assistance and personal care, eligibility for long-term care services, care transitions that Marisa pointed out, and also home health care. So again, ways that we can partner together to ensure the overall health of individuals. And as been pointed out, over 90% of area agencies on aging are doing evidence-based health promotion and disease prevention programs. So we are working to provide health-related services at the community level. In saying that, with the opportunities in the Affordable Care Act, area agencies are also working more and more on the managed care front, on Medicaid managed care, providing a broad range of services to those managed care organizations that are now working with our population group, older adults and people with disabilities. For so long they dealt with moms and kids and younger populations, but now are working in our fields as well. And to do that, we've developed partnerships with a number of different agencies, managed care, mental health, long-term care, hospitals, but I really think that there needs to be more and more growing partnerships with you all in that realm as well, because we're all working towards the health of individuals at the community level. We're all working in the Affordable Care Act, new environments with looking at ACO organizations, health home organizations, and also looking across the board. But here we've got primary care and home and medical homes as only 10% of the partnerships that we've identified. It's my hope when we do this survey again in another 2 years that number will jump significantly. In looking at that, again, one of the other things that area agencies do is they do planning for livable communities for all ages. Because what we recognize is if you really want to ensure the health of an individual, services are wonderful. But if you live in a community that is not walkable, that doesn't have adequate housing, that doesn't have services near housing, that an individual's quality of life is compromised. So over 80% of area agencies are working at the community level to ensure that their communities are good places to grow up and to grow old. They're doing this by having community-wide stakeholder groups and planning groups with elected officials and hospitals. I would encourage you to contact your area agencies on aging, see if these activities are going on, and make sure if they are that you're a part of it, because you should be a critical component of it. So as we're looking at healthy aging, making sure we choose the right road. Sometimes that's really confusing, especially when we have regulations and we have new laws and we have limited funding. What road should we be on? Well, I want to make sure that at your community that this isn't the pathway to successful aging. And we laugh at this, but too often times you see something pretty close to this happening where people really aren't engaged in physical activity and their health. What we need to do is make sure we're on the right road. And at the community level, whether you're older adults that are driving or you're on a bike or you're walking or you're on a bus, we need to work together as partners to ensure that we're on the right road for making sure that our communities are healthy places, that they are livable communities for all ages, and that we have a strong partnership between community health and area agencies on aging to achieve that. Thank you.
Okay, at this time, we'd like to open the floor up for questions for our speakers. Anybody have any questions? Well, I guess you guys have explained it all, and there's no need for any questions. So, yes, sir.
How does the evidence-based information filter through the various organizations? Does it come from the CDC, NIH, from consensus conferences? And it's obviously changing regularly. So I just wondered how that process works. I know you're doing a wonderful job, and a lot of the things, just you need the basics. But I was curious about how the system works to get new information, correct, up-to-date information.
Is this?
Okay, now I think we're on. I don't think I pressed that button hard enough. But so I think it comes from a variety of different channels. We have partnerships for developing and testing evidence-based approaches that with not only with the Centers for Disease Control and Prevention, as you mentioned, but also we've been working with the National Institute on Aging as part of the National Institutes of Health to sort of translate the research that's happening in a variety of different places around the country into practices that can then be tested as well in community settings, whether that's senior centers or community health centers or other places around the country. So I think it comes from a variety of different types of channels and eventually gets to some devoted funding that we've been able to put toward things like chronic disease self-management and diabetes self-management training and so forth. I don't know if anyone else had anything they wanted to add to that.
I think you covered it.
Okay, are there any other questions?
I had a question.
Sure.
I had a question for the other two speakers. I'm not sure if is that on. I'm always confused about where you start to look. Like it seems like in every state there's a different set of organizations, and in every community there's a different set of organizations. I mean, I just personally went through this with moving my mother into an assisted living. Where do you even, if you start, if you know you need to find supports in this area, where do you go? Is there a listserv or website or what?
Okay. All right. This one? Is this on?
Yeah.
Okay, great. Great question. And you can go, I'm just going to give you, two places to go immediately. One would be the Elder Care Locator, which you could either go to, you could call up, which is 87, wait, I always mess this up. I always mess it up. I will come back to you on that one. You go to the website, www.eldercare.gov, or go to our website, www.in4a.org. And when you go to the N4A website, there's a map of the United States. Click on, if you're looking for your mom, click on her state, and then you'll pull up all of the area agencies on aging, and you can identify them by the county or the city. The same thing on the Elder Care Locator website, and then it will connect you to the resource at the community level, to the area agency on aging. If you call the Elder Care Locator, which I'm completely blanking on the number right now, if you call there, what you will do is you will talk to an information specialist. You give the county or the zip code or the city, and again, what they will do is they will first try to find out exactly what service you're looking for, and then they will connect you, and they can directly connect you on the call to the resource, so you don't even have to make another call. The number is 800-677-1116.
Basically, it's Elder Care Locator is what to...
Elder Care Locator,
Okay.
eldercarelocator.gov, or again, you could go directly to the N4A website, which is www.n4a.org. But that, when I was talking about, and very few people raised their hands about, knowing who your area agency was locally, and some of you may have multiples depending on your service area, go to that site and find out. And I will make sure that our members know that I was here today and that you may be reaching out to them, so that they will be looking forward to your call.
And I'll just add on, in addition to sort of the Elder Care Locator, we've also, the Administration on Aging, as part of the Administration for Community Living for now the past, I'm going to get this, maybe about 12 or 13 years, have been funding what are called Aging and Disability Resource Centers. Now, these are by and large located within area agencies on aging. It is a function that can help people to sort of sort through what their what their needs are and what their preferences are for long-term services and supports. It can offer what Sandy referred to before as options counseling, and as well as person-centered planning for thinking about a person's not only an older person or a person with disabilities, but also caregivers who may be present, thinking holistically about their needs and the services with which they can be connected in their communities, as well as in many circumstances, working with them to figure out whether they can pay privately for these services or may qualify for public programs such as Medicaid-funded services and so forth. So I would also throw that in there as another good resource within your community. And unfortunately, as with every system, they're called a different thing depending on where you're located, but the name of the sort of function is Aging and Disability Resource Centers, and pretty much every state has one, and several states we've been working with most recently to develop what is called a no wrong door system, so that no matter where you go, you'll find your way into the system that can help you figure out what it is that you need, want, and can afford in terms of services.
Are there any other questions? Well, let me try this. We have time for just one more question. That didn't motivate anybody. Okay, well.
Can I just
yes.
add one more thing? I'm going to give you top 3 or 5 reasons why I think you need to know who your area agency on aging is. You have somebody coming into your office, and they're not coming up for any of their follow-up appointments. Probably the most likely reason they're not is because they don't have transportation to get back to your clinic. Area agencies on aging can provide medical transportation. you see an older adult and you prescribe medication, and then you're not sure, the next time they come in, they seem confused and you're not sure they're taking their medication. We have staff, we are staffed with social workers, but also nurses. We have folks that do medication management that can walk into the home and look at what you prescribed and what they have on their windowsill, and to try to help manage that individual's prescription, and also let you know what is going on in that regard. Also, you've got a client who just had knee replacement or has mobility issues, and you know that they're living in a 2-story house, and there's probably issues for mobility reasons there. Our area agencies on aging can also do some home modification and add guardrails and things like that to be able to ensure that somebody can really move around their own home. So those are just, as well as getting home delivered meals and home care and chore services. There's a number of things that our agencies do that will help the clients that you serve, whether they're older adults. And the other thing that I'd like to reiterate are caregivers. Even if you don't identify an older adult, most likely the majority of people that you're seeing are caregivers for an older adult. And that's a very, very stressful point in life to be in. And we have, as Marisa pointed out, through the National Family Caregiver Support Program, opportunities to help educate them, to help support them in that caregiver role. So again, I see so many different opportunities for us to partner together.
I just wanted to add on to actually something that Marisa mentioned, as well as Sandy, and I have to say I'm biased because I work for the National Resource Center on Chronic Disease Self-Management Education through the National Council on Aging, but both of you highlighted evidence-based programs, and we saw from Sandy that, what was it, over 80%? 90% of AAAs are offering evidence-based programs. The most predominant evidence-based program is the Stanford model of the Chronic Disease Self-Management Program. And what we know about managing chronic disease is that by and large, people are managing chronic disease outside of the 4 walls of a clinical institution, and that much of what's required to manage chronic disease is non-clinical. It's really about social support, role support, emotional support, and those are the facets that I think area agencies on aging help with, and the fact that you can link your clients, consumers, patients to a community-based, lay-facilitated workshop that's it's an excellent adjunct to clinical supports and services. They're incredible resources in the community. So if you don't know who your AAA is, they're likely offering these programs. Connect with them for those resources. They're great adjuncts.
Okay. All right, I want to thank our speakers again, and this concludes our second plenary session. Thank you.